and thank you everyone for being here today. We're very lucky to have this training presented by the Clinical Collaborative at IOA. Today's trainer is Rebecca Hunt, MSN, AGNP-BC, all those wonderful credentials, which makes her an expert in this regard. She's a clinical consultant, Citywide Clinical Consultation Services at IOA. Joining her are her colleagues, Almendral, who is her supervisor, LCSW Clinical Supervisor Consultant Lead of the Citywide Clinical Consultation Services, and Ashley Mooney, LCSW Clinical Consultant and Trainer, Citywide Clinical Collaborative. Becca is a nurse practitioner who also works at Stanford with a specialization in oncology and gerontology. Prior to becoming a nurse practitioner, Becca worked at a senior care facility as a patient care aide. She continued this work throughout her education. When she graduated with her BSN, she had worked for Brookdale Senior Living as a patient care aide for 7 years. She developed essential patient care and interpersonal skills during these formative years and developed a passion for caring for the most vulnerable population, our aging community. Becca worked as an inpatient nurse while completing her master's degree from The Ohio State University in 2017. While at Ohio State, she completed an internship with Central Ohio Area Agency on Aging, then graduated with a specialization in gerontology. She's extremely excited to focus her work on the aging population and to join the clinical collaborative team as a part-time clinical consultant and trainer. And we are equally excited, if not more so, to have her with us. So I'm going to turn it over to her colleague now at this time, Ashley Mooney. Thank you.
All right. Good morning, everyone. Great to see you here and great to be here with all of you. So welcome to the last installment of our harm reduction series. So Clinical Collaborative did a training series based on harm reduction. And this is the third module. The first one was behavioral health, focusing on mental health and substance use, following up with housing. And this is where we bring it to a close with reducing harm with medical conditions. So Becca is manning the slides. So can we scoot down a couple? We're going to go to our training objectives. So just to give us a little bit of overview as to what we're going to cover today. We actually don't have that many slides, so we really invite your participation, your questions, comments, and any kind of maybe case examples. And so overall, our objectives are as follows. We're going to apply an enhanced definition of harm reduction to health and getting your clients engaged in their medical care. And we're also going to discuss 8 major medical conditions that specifically impact our clients. So that's our senior populations and adults with disabilities here in San Francisco. And most importantly, I think we're going to walk away with identifying when these 8 major medical conditions require urgent and emergency care, with a little bit of a review of how San Francisco's medical system of care works and how to kind of prepare your client for what each level of medical care offers. And so this is us, Becca and myself, and the Citywide Clinical Collaborative is a joint case management project of the Department of Disability and Aging Services and the Institute on Aging. We provide clinical consultation and training to community-based DOS-funded case management and aging and disability resource center staff across San Francisco, and that's been since 2007. So we're all licensed clinicians, and we do individual and group consultations. We do chart reviews, quality assurance, and multidisciplinary team trainings. So a little bit of chat about who you guys are. So in the chat, if you could just tell us, you don't have to tell us your name if you don't want to, but your occupation, your agency, that'll help us get a handle on exactly what talent and experience is in our training today.
This is always a fun part because you can see.
Hey, open house.
Nice.
All right, fiduciaries. All right, got nurses, Open house is in the house today. Awesome. Bayview Senior
Great.
Services. Hey, awesome. So some of our clinical collaborative partner agencies are in the room, and it's always great to see you guys.
Great.
Welcome, Christy.
All right, service coordinators, we've got fiduciaries, nurses, crisis line, friendship line,
It's wonderful. Bayview.
program supervisors, self-help for the elderly is here. Always great to see our folks.
Funny.
Awesome. So it looks like we've got folks who work directly with our community. Some of them work directly with us, but lots of folks that have experience meeting the needs of this community. Great. So keep that going. It's always great for us to kind of get more detail about who's in the room, but let's move on to the next thing, which will be just like a general overview of what we're going to cover today. So first, we're going to cover four major medical conditions, and then we'll take a break for questions and comments, and then we'll cover four more, and then take another break and go over kind of the medical system of care. If you guys have been to the previous trainings, I'm into animals, and it also helps me kind of remember things. So the elephant guy is here to help us remember stuff. And the general overview of the harm reduction series has been to know your theories, first of all. And so we'll talk a little bit about, this is where you'll hear me talk, and then I'll be handing over the majority of the presentation to Becca. But we'll talk about kind of the theories of harm reduction as it relates to medicine, health management. And then step two of kind of harm reduction in the way we've conceptualized it is to know your client. So we'll cover the kind of chronic and acute conditions and awareness and insight into these conditions and their care. And then finally is knowing your options, which is going to be when to utilize emergency and urgent care and what happens at each level of care. All right, so this will be, let's see. So oops, sorry, you were right,
Sorry.
Becca. There we go. in the past trainings, we have expanded the definition of harm reduction from its initial conceptualization was harm reduction was reducing HIV and STI transmission, as well as preventing overdose, kind of limited scope. And so what we've done in this training was to broaden the expansion of harm to all of the many negative outcomes that can happen, not as a result only of drug and alcohol use, but also mental health, decompensation, and symptoms. And so we created this kind of behavioral health harm reduction, because we know that when people are unwell, even if they aren't using, they can have really negative consequences happen. And this kind of broadens our thinking of harm reduction from not just whether or not you're overdosing or not, using or not, but to whether or not you have what you need to be at your best. And so harm reduction is less of a strategy and more of a lens through which we observe our clients and our work with them. And when we think of harm reduction, we want to think of the kind of bad, scary things that can happen to folks and what we can do to stop it, slow it down, or make it happen less. So our focus today is health and medicine. So it's going to be on the major medical conditions and what are the kind of negative outcomes that we want to keep in our mind and try and prevent our clients from getting towards. And so a lot of our conversations in medical harm reduction part 2 will be, how do you have that conversation with your client about, this is a possible negative outcome that can happen. What can we do to make sure we don't get to that place? Or what are your thoughts around this possible negative outcome? And so this overall slide is just about all of the things that we consider to be harm. And so part of harm reduction is attempting to avoid these consequences or put things in place to make these things less likely, right? So if harm reduction used to be just getting HIV or getting an STD or overdosing, we have now broadened it to be all of these other things, decreasing in functioning. Death is an obvious one, but decreasing in functioning, becoming homeless or having residential instability, becoming incarcerated, and then becoming hospitalized or being gravely disabled, intoxicated, or withdrawing. And I think this other kind of less tangible thing is loss of access and loss of services, as well as loss of relationships. So all of these are kind of harm reduction, and we want to look at all of those when we're working with our clients. All right, this is the last thing that you'll hear me talk a lot about, and then I will be handing off to Becca and fielding the majority of your questions and popping in to pipe up when people have questions and comments for Becca. But I want to direct you guys to the San Francisco Community Health Needs Assessment. So you can look this up on your own time. I won't take our time here, but it was a study that looked at San Francisco and what the major needs are in our community. And there are kind of two foundational issues that are probably not surprising, but poverty and racial health inequities were things that really indicated whether or not people were healthy or not in San Francisco. And the major health needs were access to coordinated, culturally and linguistically appropriate care and services, food security, healthy eating and active living, housing security and an end to homelessness, safety from violence and trauma, and social, emotional, and behavioral health. So these are all really important things, and they're all part of reducing harm, is making sure everyone has as much access to these things as possible. So now I'll hand off to Becca, and we're going to cover the major medical conditions. We'll cover 4, then we'll take a break for questions, and then we'll keep moving. All right.
Okay. Thanks, Ashley. And thank you to everybody that came. And I appreciate all the introductions as well. I am a nurse practitioner by training. I work part-time at the Clinical Collaborative, and one of my favorite things to do at the Clinical Collaborative is to do kind of these talks, these trainings, and get to know all of you, even with these through the chat as well. So one thing I also want to add here is that I have asked Ashley to kind of chime in if something seems like a relevant question at the very moment. I have asked her to please let me know if there's something I can answer in that moment, because sometimes answering the questions in the moment is one of the best ways to kind of dive into the talk even a little bit deeper than maybe we would have even prepared for, and that can be part of the fun of it. So I just wanted to add that in addition to the breaks for the questions as well. So I'll just go ahead and get started. The things that I'm going to talk about here today include wound care, hypertension or high blood pressure, high cholesterol, diabetes, and then falls is kind of one that seems like it's on the periphery of these problems, but we'll talk about how they're all related in just a second, because then you also have chronic kidney disease, cancer, and cognitive impairment / dementia. Because one of the biggest things here I want to highlight is actually all of these are related in one major way, except with the exception of falls. Falls is a little bit separate, but they're all linked to or under the umbrella of cardiovascular disease. And I'll just kind of talk a little bit about that for a second. Cardiovascular disease is a big umbrella term that includes problems related to the heart that then cause damage to the vascular system. So all the veins and the arteries that come off of the heart, if there's any problem with the heart, then there can be damage to the vasculature of your body. And most notably, the most damage that happens in the vasculature of the body that can cause the most problems for people that are more chronic in nature is of these very small blood vessels. When you have damage to large blood vessels, that's a different problem, and oftentimes that's less chronic in nature. An example of a large vessel having an issue would be like an aneurysm or something like that, or a heart attack. But I do want to say that the small blood vessels of your body are the ones that get damaged slowly over time, and that slow damage leads to chronic conditions. And those are the things that we're going to talk about here today, these chronic conditions. And then when do these chronic conditions become an emergency? What type of follow-up do each of these chronic conditions require? So I'll just kind of quickly go through the vasculature and how like each of these is related to that. The first thing is wound care. Your body your skin is given nutrients through all these small blood vessels. And if there's damage to those blood vessels and you have a wound, it's not going to heal as well. So we'll talk about that. High blood pressure. If you have high blood pressure, there is chronic inflammation and chronic damage to the vessels that then goes down to the small vessels of the body. And that's one of the ways that high blood pressure can become a chronic problem. High cholesterol can lead to high blood pressure, which can lead to all kinds of other problems. And that makes the vessels smaller and we'll talk about how that can make the blood vessels smaller. It makes it so there's less room for blood to flow if there's deposits of cholesterol, and that can lead to high blood pressure. And then we'll talk about what comes with that. Diabetes. If somebody does have diabetes, then there is damage to the small, tiny vessels of the body, and it can lead to the same exact problems like wounds and high blood pressure and all these other things. Falls, where do falls come into all of this? Well, people that are at risk of falls are often taking a lot of medications, and some of these medications that are related to all of these issues with the vasculature can put you at high risk of falls. So we'll talk about that. We'll talk about kidney disease, how there's damage to the vessels if somebody does have chronic kidney disease, where there's a link to vessel disease in cancer and also in dementia, because believe it or not, there's also a link to cardiovascular disease and dementia as well. Okay, and I just have my notes, so don't mind my papers too. Okay, so the first thing is chronic wounds. What causes chronic wounds? And that it's what we talked about earlier. It's poor perfusion, poor delivery of nutrients to the skin. And if any sort of damage happens to that skin, then not enough nutrients makes it so these vessels can't give the nutrients to the wound needed. And then people have a really hard time letting those wounds heal. Things that often cause chronic wounds is diabetes, heart failure, hypertension, and all of these things have one thing in common. They all are related to the vasculature in your system. And the other thing is most commonly like the types of wounds that somebody might develop, is diabetes. You get those diabetic foot ulcers, venous leg ulcers. Those are related to chronic kidney disease, most commonly. Pressure ulcers, those are often related to immobility. That's a little bit different, but it's the same idea, is there's not the perfusion and damage to the vessels. And that's when somebody's sitting or like laying on one spot in their body for long periods of time, and you can't get the good perfusion that you need for wound healing. So I want to also just comment on this little picture that I have on here. Diabetic foot ulcers is sort of like one of the most common wounds that you'll see in the community. So what do physicians and providers do with these, and how do they manage them? This is kind of a nice photo that describes that process and the science behind it. And bottom line is if there's a wound that's not healing, it needs to be evaluated every 4 weeks. So that's a monthly visit to the doctor. That's a lot. And then they look over to see, if the wound is healing in a satisfactory way. If it's greater than 50% healed, then they'll start kind of peeling it away, maybe every 6 weeks, and then every 12. And they have specialists, wound specialists, that'll come in and look at these things as well. If there's a primary care doctor managing wounds, sometimes they'll refer to a specific wound doctor or a nurse that can make recommendations. And some of the goals for these wound management strategies are going to be making sure that the wound stays that it stays moist, so that it's not drying out, but also not moist with like drainage from the wound. It's really important if there is a wound that has a lot of drainage, that drainage is always cleared away as often as possible. So if you have somebody with wounds that needs dressing changes like several times a day, it's probably because that wound has been identified as being one that's has like high exudate or, like secretions coming from it. And that's going to be really important in healing. And then like wound offloading is something that they say, and that's when they're taking off all the pressure from a wound. And so it's not only pressure ulcers, but obviously that's a really common one. In the hospital, people have to be turned every 2 hours in order to relieve pressure from, like if they're laying in bed, from pressure from like their sacrum or their back. So that's really important. And that's not just for pressure ulcers, that's for all types of wounds as well. So that includes diabetic foot ulcers. And then they're looking at like the vasculature, they're looking at the seeing how things are healing, like there's certain tissue that grows on that wound that they can see looks healthy, and those are things that they're looking at every single time, and they're making adjustments every single time. And then on to when it becomes an emergency. This one's a little bit tricky. It's hard to start with like the emergency of wound care as the first slide, but bottom line is wounds aren't often an emergency. So most wounds that aren't healing are chronic in nature, and it's hard for them to become an emergency. But when they do become an emergency is when there is like an infection that becomes systemic, and the concern would be that the infection is going to somebody's blood. And so some of those things that you might be looking out for is fevers, chills, shaking, dizziness, lightheadedness. That's a sign of like low blood pressure. That can be related to infection, shortness of breath, difficulty breathing. You'll hear those a lot, to be honest. I'm going to say like fevers, shaking, shortness of breath a lot in this presentation. So, but those are, I mean, that's kind of like the bottom line is if there's an infection on a wound, not often an emergency. If the infection goes deep enough and it's going into the blood in some capacity, then it's an emergency. And then somebody can go to the hospital or be seen by their primary care doctor immediately for something like that. But to be honest, and a visit to the hospital is warranted. And then when it's not such an emergency, it's like, you're seeing the wound grow, or you're seeing a lot of redness around the wound that keeps growing and getting worse over time. Those are reasons that it's not an emergency, but a visit to the primary care doctor or the wound specialist is warranted. Okay, now I'm moving on to high blood pressure. So high blood pressure is, I think a lot of people know this, it's so common, but it is when the force of blood that's going through that vasculature that I talked about, your vascular system, is higher than it should be consistently over time. That is considered to be high blood pressure, and that can be damaging to those vessels. And so, because high blood pressure is like one of the most common things that you're going to see in the community, there's a reason that the American Heart Association has really strict guidelines for this, because it is just so well researched. It's so well followed, and they have really specific guidelines for where people's blood pressures need to be. And so I just have a photo here of the JNCA guidelines, and they get updated every few years about where they want people's blood pressure to be, and what kind of like how the management is for doctors, and like where they need to put the goal. And it's surprising, you'd be really surprised to learn that actually normal blood pressure is supposed to be less than 120 in the systolic number. That systolic number is the top number. So less than 120 is the goal. And I think that might be news to some people. It was to me, like when I first learned that. Yeah. So, and the reason is it's because like 6 or 7 years ago, it used to be that anything greater than 130 was considered to be high blood pressure. But they have researched it so aggressively over the past 10 years. They have determined that actually people's outcomes and like risk of death is higher over like many, many, many years. I don't mean to scare anybody, but I just mean like over a lifetime of having a blood pressure that's like 129, a systolic blood pressure of 129 compared to like 120, there is a difference. So that's why the primary care doctors in the community are really harping on blood pressure less than 120. And then it kind of goes from there. Elevated is 120 to 129. You're considered to be stage 1 hypertension if your blood pressure is 130 to 139. And then stage 2, 140 or higher. And then if you're over 180, that is considered to be a hypertensive crisis, quote unquote. And really a hypertensive crisis is considered to be that high blood pressure combined with symptoms, especially. So the symptoms of high blood pressure are like a headache, it can be like vision changes, it can be especially like a headache that won't go away, or those vision changes, like I said, just like generally not feeling so good. They're kind of vague, but those can be signs that there's damage being done to your organs in your body, because your vessels are delivering all this blood to all these organs. And if your blood pressure is too high to the point where it's in a crisis mode, then that means it has to be combined with organ damage and that high blood pressure. So it's kind of both, but the way that they can really measure it is that high blood pressure. And then I could get into how they measure like organ damage, but that could be a whole nother talk. So things that I just want to comment on here first is that, when you bring someone's blood pressure down, people can, if your blood pressure is super high and you've got these symptoms, you have to go to the hospital. And we should be encouraging like any sort of client that we have to be evaluated immediately if they like are taking their blood pressure at home. And they find a number like that, then they should be seen by a doctor or like go to the hospital, so they can look for the signs of like organ damage related to that high blood pressure. And in the hospital, you could expect for the blood pressure to be brought down slowly, because you can end up giving people a lot of like symptoms and like dizziness, lightheadedness, and all of these things that are related to blood pressure being dropped too quickly. Okay, so high blood pressure, like in terms of an annual like a follow-up, it is an annual follow-up with a doctor. And normally a primary care doctor can just manage people's high blood pressure. And the high blood pressure is managed with a blood pressure check every single year. And people, if there is like a need to adjust a medication, then after that, then the doctor would likely want to see the patient within a month to recheck the blood pressure. And then anytime there's changes to the blood pressure regimen, then the expectation should be that the client or the patient needs to go back in every month or so until you have a really good controlled blood pressure. Then you can expect like an annual visit.
So we've got like a couple questions, but they can wait. But yeah, I want to encourage people. We are going to take a question and answer like discussion break. So like think about, I think we'll have plenty of time also. So think about like if you have specific questions around each of these conditions and a client of yours, don't feel limited in any way. You can put them in the Q&A box and we will address them in just a little while. But yeah, Becca, people are saying stuff, but why don't you just encourage people? You can say more. We'll just be taking a little time after. And I have questions, so don't worry.
Perfect. Okay. Great. So the next thing I want to talk about is high cholesterol. And cholesterol is this sort of like waxy substance that your body makes. Your body makes it, and it's made in your liver. Your liver makes this substance. It's responsible for helping make cells in your body, vitamins, nutrients, things that your body needs. Cholesterol helps carry all those things too. But there's another way that your body gets cholesterol, and that's from like animal fat and like in consumption through your diet and stuff. But most commonly it's animal fat. So there are different ways to measure, or there's two different types of cholesterol. There is high density lipoprotein cholesterol, and then there is low density lipoprotein cholesterol. And there's a good cholesterol and there's a bad cholesterol. So people would talk to you about like, oh, your total cholesterol, your good cholesterol, your bad cholesterol. And we'll talk about what that means in just a second. But the thing I want to talk about as to why people even care about cholesterol is that when there is too much cholesterol, specifically the bad cholesterol, it deposits into the vasculature of your body. So if there's extra, there's nowhere for it to go other than in mostly the arteries of your body. And then you're decreasing the sort of like diameter of the flow of the artery. And if you decrease the diameter, then you're going to increase the pressure. So there you have it. That's how high cholesterol can lead to high blood pressure. And then high blood pressure leads to damage of the small vasculature of your system. And it kind of goes from there. So you can see how all of these things are linked. And that's kind of one of the biggest points that I wanted to make in this talk, is how all of these medical conditions are actually linked to each other. And how also follow-up care is so important, because we're talking about all of the importance of annual follow-up, so you can check these numbers, new medications to make sure that they're working. So access to care is really important. So we'll talk about all that stuff later, but I'm kind of just like planting a seed now. I'm kind of going to tie it all together in a little bit. But high cholesterol, bad cholesterol, good cholesterol. There are also very definitive guidelines about cholesterol, where we want to see cholesterol. And that's because it's been, again, so well researched. They know that if somebody has a cholesterol that's higher than 240, that you're putting yourself at risk of like getting higher blood pressure. And actually they know that outcomes for your life, an entire lifetime of having a total number of cholesterol being 240, it can affect your lifespan. So, where did I want to go with this? So the bad cholesterol, when your body makes the good cholesterol, it's all made in your liver. And then when you have extra of that good cholesterol, it gets deposited back into the liver. And then if you have too much of the bad cholesterol, then like I said, that one's the specific one that goes to the artery. So like if you hear people say this thing like, oh, I'm eating this burger and it's going straight to my arteries, that's kind of real. So
vivid imagery.
I know. I just like, when I was writing this talk, I was like, oh yeah, I got to mention that, because it's like, I don't know, you just kind of remember it. So in any case, this is another case where cholesterol being high is hardly really ever an emergency, but you can see how it can be linked to things that do become an emergency, how these things build up over time, chronic conditions becoming emergent conditions. So like, high blood pressure, as we know, it can lead to high blood pressure, and then it can lead to hypertensive crisis. If there is hypertensive crisis or an hypertensive emergency, then you've got the damage to the organs, and then it can go from there. So that's like where it can become an emergency, like long term. But that's where it becomes important to talk about follow-up. What kind of doctor visits do we need? What kind of annual follow-up do we need? And the expectation is that for a healthy person, every 4 years, with no other medical conditions, a check of a cholesterol every 4 years is okay. But if somebody has any sort of other medical conditions, especially if they have any sort of other vascular conditions, cardiovascular conditions, then they should be having their cholesterol checked every year. And, you know, that goes especially for people with, yeah, like I said, like a family, even a family history of cardiovascular disease. Your doctor might ask you to come in every year to get your cholesterol checked. So then I just have, the last thing is I have this little imagery of high cholesterol and like what the goals are. 240 or higher for your total is like, you don't want it to be any higher than that. And then, you know, you want your good cholesterol to be less than 200. And they don't even have, I mean, for your bad cholesterol, they just want it to be less than 40. That's like the goal. And there's no number for like the minimum. And then the last thing is triglycerides. Triglycerides are on this imagery because triglycerides are closely related to this. They're not all the exact same thing, but they work in similar ways. And triglycerides are basically like a protein, like a chain of proteins that are derived from like fat. So you get that from your diet mostly. So that's why also they ask that your triglycerides be less than 200. Okay, so I can
There's a lot
go.
going on in the chat, Becca, but this is good. This is why we have a break. So we'll be able to address everything kind of all at once.
Okay, okay, good. I'm kind of relieved because I'm talking a lot.
That's what this is for.
I definitely want people to ask questions because I
There's
can.
a lot to share for sure.
Yeah, and
They are, but that's why we're setting aside like an actual time. We'll go over everything. So
okay, perfect. That sounds great. I'll, you know, one of the things is that when you're in the position that, like, I've been now at this point in like the medical field talking about in some way cholesterol, diabetes, all these things for like over 11 years. And so sometimes I can just like talk about it in a way that I don't even realize is like, I don't know. So just let me know if I'm like using jargon or saying things that like don't even make sense to people. But okay. So diabetes is the last thing I'm going to talk about. And then I'm going to take a bunch of questions, hopefully a bunch.
Yep.
Okay. So diabetes. This one is interesting because I think most people know this, but some people don't. And diabetes is divided into two types. There's type 1 diabetes, type 2 diabetes. And type 1 diabetes is often diagnosed in childhood. And it is something that is mostly, it's not something that you can like develop. It's usually something, well, it's, okay, I shouldn't say that. There's some autoimmune problems that can happen later in life where somebody can develop type 1 diabetes. I digress, but usually it is something that develops in childhood, and it is something that is in the genome of that child, and not necessarily that it's passed on from parent to child, but it is something that like it's like a genetic thing, and the way that child is, and that means that child is completely like their body does not make insulin, and the pancreas is the part of the body that makes insulin. And if you have type 1 diabetes, then that person doesn't make insulin. That's a big difference between type 2 diabetes. Type 2 diabetes is where a person develops it later in life, and that is a result of diet. It's a result of like lifestyle. And if somebody develops type 2 diabetes, it's in fact where their body is resistant to insulin, and they're resistant to the insulin that their pancreas makes. So there are ways that your body can then there's medications that you can take to bring your blood sugar down in different ways. So that's why, if you've ever wondered why maybe one is called insulin dependent diabetes and one is not, and one is not insulin dependent. And the reason is because type 1 diabetes, their body makes no insulin at all. There's no way to decrease blood sugar other than giving insulin. So childhood onset diabetes, insulin dependent diabetes, these are all ways that you can characterize that. So those people need insulin injections. There's no other way around it. And type 2 diabetes is when you're, like I said, your body's resistant to the insulin that your pancreas is making. So you can decrease blood sugar with pills like metformin, which will decrease your production of sugar like through your liver. And you can also get rid of, I think like, I didn't create a whole thing about medications, but there are other medications that you can take that kind of go from there. Metformin is one of the first things, and then you can take medications that make you urinate out most like extra sugar and stuff. And there's a class of the class of medications for type 2 diabetes is so complicated, and that's because there's a lot of different ways that you can attack it. And with type 1, there's only one, it's insulin, and that's it. And just so people know, insulin makes it so like the sugar that's in your blood, it opens up like a channel in your cells where it then takes the sugar that's floating out in your vasculature and it takes it into the cells. So it makes the blood sugar, what's floating around in your blood, it makes it lower. That's kind of like the mechanism and the way that insulin works. So I want to also talk about follow-up, about how often people need to be seen for this, and for a really nice, like a good controlled person with diabetes, like you can go every year. And every year somebody will take, your doctor would take a blood test called hemoglobin A1C. And hemoglobin A1C it's a sensitive blood test, and it measures an average blood sugar of 3 months. This is a really nice way to, if for somebody that's like not taking their blood sugar at home normally, like say they just take metformin and they don't have to prick their finger and take their blood sugar. A lot of doctors will just do a hemoglobin A1C so they can get an average blood sugar test. But if consistently a patient is coming into the doctor and they're consistently hemoglobin A1C is higher than it should be, then somebody like a doctor might say, okay, like you've just bought yourself, a blood sugar checking kit for home, and you have to start checking your blood sugar like every day. So that's where you might see somebody like only on pills, but also having to take their blood sugar at home, stuff like that. Okay, and then when it becomes an emergency is, blood sugar is like one of the most important things that can affect blood sugar is really important in delivering like nutrients to your body, and especially your brain. You're having a sugar greater than like 60 or 70. This slide says 70, but like in the hospital, if it's less than 60, then it's emergency. But maybe like in the community, the number might be a little bit higher. But that at that point, if the blood sugar is lower than that, then you worry that you're not getting enough blood sugar to your brain. And that's responsible for firing all the neurons and all these things going off in your brain. It's driven by blood sugar too. So it's actually very important. And if somebody has low blood sugar, it can be deadly. So if anybody is like CPR, like BLS, what is that? Basic life support certified. I know a lot of you probably are. That's one of the things that you are supposed to do if you find somebody that's unconscious and you like don't know anything about what happened to them. or they're like super dizzy or like altered, like their mind is altered or something, then you're supposed to give them like little dextrose or like sugar pills. And that's because low blood sugar, it can like change things very quickly. High blood sugar, on the other hand, is not as dangerous in like a fast setting, but diabetic ketoacidosis can occur, and that is an emergency. And diabetic ketoacidosis is typically like if your blood sugar is greater than 400. And the way that becomes an emergency is like if your blood sugar is so high, it can change the pH of your blood. And that like, yeah, pH is, you know, like how acidic your blood is. And if basically that acidosis part is your blood being too acidic, and it can be toxic, and then like that can kill you. That usually happens a lot slower, but typically where you'll see diabetic ketoacidosis emergencies is through people that have poorly controlled blood sugars for a long time and like just don't know it. And then they find out that they have diabetes when they're admitted to the hospital with diabetic ketoacidosis, and they find that they're, you know, tired or like nauseous or dizzy. And the thing that's crazy about it is high blood sugar and low blood sugar have similar symptoms, actually. So it's like this shaking, tired, rapid heart rate, dizzy, nausea, throwing up. All of these things are actually high blood sugar and low blood sugar symptoms. And then one more thing I want to add about like the doctor, how often like a physician wants to follow a patient for diabetes is if they're first like being diagnosed with diabetes or things like that, or they're being watched for diabetes, it can be every 3 months for that hemoglobin A1C, because remember that's the average of every 3 months where they're drawing that blood. But one of the most important things that they do for anybody that has a diagnosis of diabetes is doctors will ask those patients to go to an ophthalmologist or like an optometrist, an eye doctor every year. And you know why? It's because there's tiny little blood vessels that deliver all the blood to your eyes can be damaged by diabetes. And that goes back to this whole theme of like the vasculature that we've been talking about. They also ask that diabetics will look at like the bottoms of their feet for wounds, at least, you know, they say like at least every 3 months they should be doing that, or more often. But the doctor themselves will check any diabetic every single year. They'll look at the bottom of their feet, just like with their annual visit. And again, that's because the small vasculature in the bottoms of your feet and like your toes can be damaged. And then they also ask that you, like all diabetics, have to get kidney labs, or like a creatinine is the number that they look at in the blood for how well your kidneys are functioning. And they always check that because your kidneys are one of the most highly vascular organs in the body. And so there's tiny vessels in the kidneys that can be damaged if somebody has diabetes. And all of those same follow-up sort of needs exist for people with high blood pressure and high cholesterol as well, but more so with the diabetes. And that's also because usually people with like the combination of diabetes, high blood pressure, high cholesterol, and some of the other things we're going to talk about in a bit, the combination of all those things is an even more of a reason to better control all of these numbers and go to those follow-up visits. So again, access to care is so important if we're asking people to, you know, these diseases are pervasive in the community and they're all linked, and they can all lead to this kind of funneling of like bad outcomes for people if they're not being seen by a doctor and if they're not having these things well controlled. Okay, that is everything I have until my next little set. So let's talk, let's chat. We still have, I only have like 3 or 4 more topics. And then
we've got
and
the
then-
medical system of care. Okay, Becca.
Yeah.
So thank you for that. Let's see. We have, so the major conditions we went over were hypertension, cholesterol. Now it's a memory test.
You're funny.
I think we'll open it up.
Yeah, so the crowd is obviously muted, so we can't have them pipe up, but there have been, I guess we'll go from kind of most recent back. Most recently in the chat was someone saying, you know, I work with clients and their doctors are not asking to see their feet. And that I tell my residents to take their shoes off and make sure their doctor checks their feet, capillary refill, and uses the filaments for neuropathy. And also prompting the residents to try and check the bottom of their feet with a mirror on their own. So what do you have to say to that?
I would say that it is a standard of care for somebody with diabetes. Annual visit, there should be a foot check, no questions asked. So my answer to that is, you know, if a doctor thinks that their client or their patient's blood sugar is very well controlled, perhaps they could use their clinical judgment to forego the foot test. I think that that's reasonable, but that doctor has to really know that the blood sugar is really well controlled if they wanted to forego that. But the standard of care is that the bottom of the feet are checked during an annual visit every year for people with diabetes. Right. I would say that if you know that there's a client that does not have well-controlled diabetes, like if they're taking their own blood sugar at home and you know that their blood sugar is not well controlled and they're not getting that foot check, that's where advocacy would be important. And it's it's a shame that would lie on the case manager or the patient. But I guess that would be my answer, is that then advocacy would be the next step. And I like the idea of checking it themselves. Clients checking it themselves with mirrors. Doctors will tell their patients to do that too. So I think that's awesome. If clients can do that, and if you can trust your clients to do that, it's great. It's an awesome idea. The mirror thing is really good. Another thing that people often do is this person mentioned neuropathy, which is really, it's an important piece of this, because one of the reasons that people end up getting, people with diabetes end up with wounds in the first place is not only the damage to the vasculature alone. That's one of it, part of it, and then partly because those things can't heal as well, but also because there's damage to the nerves. The tiny nerves that go to the bottoms of the feet and the toes are damaged as well. And that's where that neuropathy is relevant and important. And then if there's damage to the nerves, somebody with diabetes hits their foot on something, they can't feel it as well. Yeah. And they can't feel that wound develop. They can't feel that wound get worse. And you can see then how people end up with terrible outcomes related to foot wounds and how that relates to diabetes. So thank you for bringing up neuropathy, person posing that question.
Awesome. Then we've got, this is maybe more of a statement around kind of the complexity of multiple medical conditions. And then we're going to scoot a little bit into kind of diet and cholesterol questions that came up. But Heidi says, this isn't really a question, but just a statement around managing multiple conditions can be really challenging. One kind of chronic condition is hard, but what if there's multiple ones? So the specific example was Parkinson's, osteoporosis, cancer, and also on top of that, maybe heart disease or diabetes or some combination that these are hard to deal with. And then managing the medication kind of regime for that has got to be really complicated too.
Yeah, Heidi, you're absolutely right. And I think that's why medicine has become really siloed, because it's become so complex over the past 100 years or whatever. The last century, things have become very siloed, and that's why like a gerontologist is such an important part of the medical group, because a gerontologist is trained to focus on diseases that affect specifically people of older age, and Parkinson's would be one of those things. Osteoporosis would be one of those things, and those gerontologists are also trained to like look at somebody's full medication list and think about how those things are affecting each other and affecting the client as a whole. And I think it speaks to something that's a big problem in medicine is, even trained gerontologists or, a really, really good primary care doctor who is taking a lot of time to look at the whole patient, look at the whole medicine, regimen, and then see how that affects the client and, how their lifestyle, and then, who they are as a person. Even the people that are the best at that, the doctors that are best at that, are still not always able to get it all right. And you bring up a really good, important point about how difficult it can be to manage all of these complex things in people with multiple comorbidities, is what we say in like the medicine world. And there are a lot of trainings and things focused on that problem and how we can better tackle it, because at this point, I agree, it's difficult and we're not doing as good of a job as we should.
Awesome. Yeah, and I think this is just another reminder for our case management folks out in the internet, that your medication list is something that you can use as a point of getting to know your client, but also a point of advocacy, right? Making sure that the client's medication list is up to date and that the doctor is aware of what another specialist is prescribing to your client, so that everyone can be kind of looped in on the complexity that can happen with multiple conditions. Okay, switching gears a little bit here towards kind of cholesterol, blood pressure, and diet. So there was a question specifically around cholesterol. Are there diets that can make cholesterol management more easy? Are there ways to reverse high cholesterol or bad cholesterol? Then there's a kind of sub question around keto, but basically diet, cholesterol, what's the sitch?
Yeah, so I would say that you can decrease your cholesterol. You can even decrease your blood sugar, your hemoglobin A1C. You can reverse diabetes. You can't, if you are a diabetic, you can't completely make it all go away. If you're pre-diabetic, you can actually reverse pre-diabetes, all with diet and exercise. And there's a lot of like conflicting stuff about what the diet looks like that is best for that. But what the mainstay has been, and that really hasn't changed from the recommendation of the American Heart Association, is those kind of like a heart healthy diet includes things with like good fat, like oil, like an olive oil instead of like a butter, and then things like specifically staying away from things that are like solid at room temperature, because those things are like directly, they mostly come from like animal fat. But if it's like a derivative of like a plant or something, typically it's a little bit better, and especially if it's like a liquid at room temperature. So that like the Mediterranean diet, I think, is like the way that we describe that. So like, yeah. Those are, and then exercise actually it's huge. I mean, diet is super important, but exercise can play a big factor, and it doesn't need to be vigorous exercise, where you're like lifting, you're like a weightlifter or something, like even if you're getting your heart rate elevated for 30 minutes every day, then you can actually make things get better.
Awesome. What about keto?
Yeah, I can pipe in there. I've had personal experience as well as people telling me that keto diet has saved their lives. They lost 30 pounds, 40 pounds, and they overall, all of their biometrics have improved. So basically, to review, so the keto diet, healthy keto diet is actually 75% fat, 10 to 30% protein, and no more than 5% or 20 to 50 grams of carbs a day. So it's basically cutting out all carbs, cutting out all sugars, or most carbs, all sugars, and sticking with a very high fat, high protein diet. So it's worked for some people with regard to a target weight loss within a short period of time. I think where we also need to be concerned about, though, is it can cause low blood pressure. It can create kidney stones because you're basically eating mostly just fats, which can produce kidney stones. For some people, they've also experienced constipation, which is very uncomfortable and not to mention, painful. And also it can lead to nutrient deficiencies and therefore an increased risk of heart disease. So I think the other thing is, obviously with the pandemic, people are staying home, eating more at home so they can control what they're cooking and eating. But it also can do social isolation. You basically are restricting what you eat and limits your ability to go out. The other thing is for those people who have pre-existing conditions that relate to their pancreas, liver, thyroid, or gallbladder, it's really not recommended. So the bottom of it is make sure that let's not go to extremes. Check with your doctor. I think Becca has mentioned that the regular checkup is amazingly helpful. It's probably the best preventive practice we can do recommend for our clients and do for ourselves. And just being informed about those kinds of things. Everything in moderation. I think in my generation of people, we always had this idea that if you had a plate that looked balanced, most likely it is. So I think moving away from extreme diets is probably what we would suggest.
One thing I want to add to that, which I think is important, is like kind of what Anna is saying is like extreme diets are like never really the answer. When you look at like a Mediterranean diet, when you look at a keto diet, some of the biggest things is like the focus is lean meats. The focus is vegetable heavy, like plant and vegetable heavy diets are known to be heart healthy. And I actually just looked up like the American Heart Association just to like check to see what the American Heart Association says about keto diets. And they did say that one of the benefits that they see that people comment on is like it can decrease like Anne was saying, like less carbs, sticking to not like completely eliminating carbs is very important. Like Anne was saying, don't go extreme with it. But if you are limiting the amount of carbs, especially like the simple carbs, like, white bread or like potato or something like that, that's like, well, I guess potato is more like starch, but the thing is like those carbohydrates are broken down, the simple ones especially are broken down very quickly into sugar. And so limiting the amount of sugar that you're intaking, but also remembering that carbohydrates are important as well, because we talked about sugar. We talked about, like Anne was saying, some people end up with low blood sugar. We know now how dangerous that is to have low blood sugar. You don't want to risk that. And so carbohydrates are an important part. So don't take it to the extreme and completely eliminate them. But the American Heart Association recommends like whichever diet you choose, the Mediterranean diet or keto diets, keeping it balanced and keeping it like vegetable and like fruit, like plant based, is one of the good ways to do, to get a lot of the nutrients that you need.
All right. So scooting back even further, we have kind of some thinking around blood pressure and hypertension. So this is more kind of about home management, but can you just tell everybody how you manage blood pressure at home? I know you're talking about blood pressure checks, but technology now has made blood pressure and heart rates and all these things infinitely more kind of accessible to do at home. So could you tell us a little bit about that? And then I had a question on how blood pressure specifically is diagnosed, right? Because you can walk in with high blood pressure, like with numbers that fall high on that chart, but does that necessarily mean you're given a high blood, like a hypertensive diagnosis? So sorry, two questions.
Yeah,
One, home
yeah.
management. Two, how would a hypertension diagnosis be given?
So this is based on my memory. And so if anybody knows anything different, please feel free to correct me. But I'm pretty sure it's 3 readings in a row.
Okay.
Is a diagnosis. But also there's something that's really important to be said about that, which is this like white coat syndrome, if anybody's heard of it, with like high blood pressure, where people get nervous about being at the doctor's office, and then they're nervous for being there, and then their blood pressure is high. So if you or somebody you know, or your client, or anybody is getting a consistently high blood pressure reading, where it's like 3 in a row, and you are curious about maybe avoiding like a medication or something, try taking it at home, and your doctor might recommend it too. And so you can, or like go to Kroger and, go to one of those like things where you put your arm. Oh, we don't have Kroger's here.
Your Midwest is showing.
Oh my God, so funny.
That's awesome.
So go to one of the things at the grocery store where you like put your arm in it, and like maybe you'll be less nervous there. Or you can buy a blood pressure thing just like for your wrist to get your blood pressure measured there at home, where you're just a little more comfortable and not so nervous, because white coat syndrome is very real, and it's well researched in the medical world. So pretty sure it's 3 readings. White coat syndrome's real. Try checking it at home. And then in terms of home management of diabetes, is typically what a primary care doctor or like even a cardiologist will have somebody do if they are starting a new medication, is they will tell people to buy a blood pressure cuff. And again, like this is where access is so important. Like if somebody is being told to buy a blood pressure cuff at home because it's necessary for their management of their blood pressure, is that possible for everybody? And it's not. But so, I mean, in some situations, maybe it's possible for like that doctor to then, write a prescription for the blood pressure cuff to then try to get the insurance to pay for it and all of these other things. Like there's ways around it, but you can just see how it's like, it's a barrier. But a lot of physicians will have patients start a new medication and take their blood pressure every day at home and write it down. And then they have to come in with a sheet of paper with all of their blood pressure readings for the past few weeks. And usually it's like a month. And then they can like adjust medications from there. And then just like diabetes, blood pressure medications, I could go on and on and on about those, about different ways that they work, how you start, how you go down the line of which ones you want to pick like as an alternative. So if anybody in this chat has received one of my chart reviews where I like look through a patient's medication and I'm like, oh, interesting blood pressure medication. This is like a 3rd-line blood pressure med. This person must have like really a difficult time controlling their diabetes. Those are things that are like something to keep in mind. Is like blood pressure it can be different for everybody. It can be really hard to control, and writing them down at home is one of the best ways to know if a medication's working.
Awesome. Okay. We've got 3 questions in the chat. Plus we have a couple things about diet. So we've three different directions, but so Jesus has got some questions specifically around blood pressure. And so the one is, when should, we kind of covered this, but high blood pressure, when do you know, oh no, I need to go to the ER? Looks like someone just started taking a new blood pressure medication too. So maybe low blood pressure could be a concern also.
Yeah, that's a good point. Low blood pressure is definitely a concern. Like, we have people admitted to the hospital after falling and like hitting their head or something like kind of traumatic, all because the blood pressure medicine that they were put on drop their blood pressure too low. And in some instances, it happens that, you know, you get the 3 readings of high blood pressure in the clinic, and then really somebody's blood pressure is okay at home. Then they get put on a medication, and they actually didn't need a medication that, you know, that strong or something. But to answer the question about how do you know if your blood pressure is too high, that the answer is, you know, measuring it for one. If you are suspicious that, you know, you or your client has a high, like might have a high blood pressure reading, then go somewhere to get it measured. And then the symptoms are like vision changes. Specifically, some people see like people can see like double vision, or people can see like little like flashes of light. These are all things that like you know, the vascular system like in your eyes is being compromised, and like this is oftentimes associated with a really bad headache, especially if like you take a ibuprofen or something and your headache doesn't go away, and you have this concern for like vision changes. Those two things combined, maybe you'd be suspicious if like, you know, that you have high blood pressure, your client has high blood pressure, and they have those symptoms. You might be suspicious, and you might want to get the blood pressure number checked.
All right, cool. Let's see. We've got one diet question and then another blood pressure one. The diet one I think should be a quick one because I am tracking. We got 45 minutes and we still have some more conditions to cover. So the diet question, is it still recommended to eat protein at the same time as eating carbs?
I think so.
Okay. Like
sorry,
I said, that one might be quick.
I wasn't aware of a recommendation that protein and carbs should not be consumed at the same time. But I'll just harp on one thing again. You know, you remember the food pyramid from when we were kids? No, or, you know, maybe not everybody was kids, sorry. A food pyramid from like the 90s. Now it's like a plate. And like looking at that and recognizing that those sort of like those recommendations pushed by the CDC are really well researched, and a well-balanced diet. If you go to like CDC's website of like, you know, they have like now a plate for like how much of your plate should be protein, like a meat protein, how much should be vegetables. Following those, it's, you know, it's one of the best ways that you can make sure you're getting a well-balanced diet.
All right, quick, let's see, question from Aiden at Open House about cholesterol and alcohol. So a client may have access to a healthy diet, be exercising and consuming alcohol. Is cholesterol impacted by that?
Well, alcohol has a lot of like calories, and like your cholesterol and alcohol are associated, because if you break down like the number of like calories per gram in a protein, it is, I can't remember the numbers now. I think it's like 4
okay, it's not a pop
per
quiz.
gram. Yeah, but the point that I want to make is that alcohol and fat, like actually like a stick of butter per gram, they're the same. It's like 9 or 10. So my point is, alcohol is very calorie heavy, and it has basically no nutrients in it, and it is associated with high cholesterol.
Okay, let's see. There are a couple more questions. This one is a little bit kind of outside of the general. Let me make sure I'm covering all the stuff that's on the topics that we have. Callan had a question specifically about high blood pressure in the older adult. I think that there was historically a thought that for older adults, the numbers that you would use for a hypertension diagnosis were higher. Is that still the case, or has everyone been put into that same category?
So the JNCC guidelines does have different categories for people that are over, like, I think 75, but it also is up to the clinician to decide how many years the clinician would expect that this client has left to live. So like a 75-year-old is not the same as like a really healthy 75-year-old is not the same as like a really, unhealthy 55-year-old or something. So it's very complicated actually. And I could do a whole talk about blood pressure management and like those goals. But for the general population, most people, the goal should be less of like 120. But Catlin is right that it is different for certain people, especially if there's like an older person that might be at risk of like a fall because their blood pressure is too low. Then a doctor might aim for a lower or for a higher blood pressure. So it's very nuanced, and thanks for bringing that up, Catlin.
Okay, fantastic. There's one question on differentiating between weight gain and inflammation, specifically with HIV, but I think we might put that for later. Becca, did you want to take 5 now? And then when we come back, we can do the rest of the conditions, or do you want to push through? Up to you. We got the 4 conditions.
We might have, let me push through and then answer, and then we'll take like a 5-minute break after we talk, just so I can make sure that we get that done.
That was kind of what I thought. Okay.
Okay, cool.
All right. And Jesus, I have not forgotten your questions. I will leave them in the Q&A, and we will hold them for later. Everyone else, I think I will indicate your questions are marked. And all right, Becca, back to you.
Excellent. Okay. Thank you so much for all the questions, you guys. It's really helpful for me to get into like the nitty gritty of these things that I wouldn't otherwise have gotten into. Your participation is really valued. So I just want to say that. Okay. Next, falls. This is an interesting one, an interesting slide, because you can see how like maybe this one wouldn't be so ingrained in the cardiovascular talk. But the reason that it is, and the reason that I included it, is because falls are very associated for a lot of people with age, and also people's medication regimen and their list of medications that they take. And the reason I wanted to bring it up was because high blood pressure and people that take medications for high blood pressure you can find that people have a drop in in their blood pressure as a result of those medications. And that can lead to falls. So patients taking blood pressure medications always think about what the mechanism of the fall was. If you ever have a client that has a fall, did they trip over something, or did they get lightheaded, dizzy, and fall? It's always something that I ask. And it's always something you should be asking your clients if you ever learn that somebody fell. And I just put like a little statistic at the beginning about 3 million older people are treated in the emergency room for falls every year. And the point is it's very pervasive. It's very common. And then another very interesting fact that I wanted to add is that a vitamin D, there was a study in, I think, 2016 or something that came out, and they found that if specifically women over the age of 65 were medicated with a vitamin D supplement, their risk of falls decreased by like 42% or something. Let me double check my number. Wow, I was right, 46%. And the point here is something that somebody else touched on earlier. It may have been Heidi, I can't remember, but there is a huge association with these complicated comorbidities and aging, what aging does to us and how it can affect our bodies. So we didn't even go back in this, they didn't go back in this study and like draw people's vitamin D levels and like their calcium levels and stuff. They just put everybody on, especially women, on a vitamin D supplement, and found that the falls decreased by 46%. It's a big deal because it shows really, how these things are all all communicating with each other. And especially, earlier somebody mentioned like osteoporosis and like how this all can be factored in, and like a primary care doctor might need to factor in the fact that somebody has osteoporosis or Parkinson's, and their risk for falling is really, it's a lot higher. So they might not treat blood pressure in the same way. And then also making sure that, they might not give as high of a dose of a blood pressure medication. They might not even put somebody on a medication to thin their blood. Like say if somebody has a high risk of stroke, they might not put them on like a medication called Eliquis or like a blood thinner, because if their risk of falling is so high. So there's all of these different kind of nuances that doctors, physicians, providers need to think about when they're medicating older adults. So yeah, that's where I wrote, like in the interventions, doctors need to look at the list of medications every single year and evaluate for this risk. And eye exams are important because the vasculature of the eyes, we know this, we know why that would cause a risk of falls, right? If you can't see something in front of you. And then the foot exams, the vasculature in the feet, we know this because if you can't feel what's below you, you can see why you might be at risk of falls. So you see where all of these things are very all communicative together, and they all are related. And then also, like, this is just kind of one little piece here, like why medication reviews are so important. Not only like blood pressure medications can be a risk factor in falls, but also antidepressants and like pain medicines and other things too. Like it really runs the gamut. And I'm kind of all over the place, but I want to go back to that blood thinner thing that I mentioned. It's not that putting you on blood thinners puts you at risk of falling. It's that if you fall and you're on blood thinners, then you have a bigger risk of having something bad happen to you. So I just want to specify, because I think I'm kind of jumping all over the place because I'm trying to go fast now.
You're not as all over the place as you think.
Okay, thanks. Thank you. I knew that. Okay.
Tracking.
Okay. So here's a really fun little thing that I added in this slide is a QR code. This QR code exists on the CDC's website, and they have a whole community program focused on fall prevention for older adults. So if you like hover your smartphone over that, you can pull up this like really long document that the CDC developed. And some of the things that's in there include annual doctor's visits. It includes medication, reviews. It includes older people doing Tai Chi. That's why we have that picture in the slide too. There's a big focus on like the American like Gerontological Society is focusing and pushing on patients and older people learning and doing Tai Chi because it helps so much with balance and strength. And they found that there's a lot of studies that show it reduces fall risk as well if people participate in this. There's also a whole fall risk plan reduction for making sure that older people have good lighting in their house, that they're removing throw rugs from the ground, things that they can trip on. And then like finding very specific places to add railings in the house and things like that. So falls are important. They're related to this all. It seems like an interesting thing to add in, but as you can see, it's all very related. Okay, next, chronic kidney disease. Chronic kidney disease is very common. I think I added here just like a little statistic about being the 9th leading cause of death in the United States, because chronic kidney disease, it affects a lot more people than a lot of folks think. And one thing that I want to add is why I'm bringing it up is that your kidneys, like I said earlier, the vasculature of your kidneys, it is one of the most vascular organs in your body. So if there's damage done, your kidneys are going to be one of the first things to take a hit. And be damaged, so to speak. So the kidneys filter your blood. The whole job of the kidneys is to filter your blood. The byproduct of that filtration is urine. So you're urinating out like all of the toxins that your kidneys are taking out of your blood. So you can see if you don't end up having or if your kidneys are damaged and they're not filtering your blood as well, how you might have a buildup of this toxic waste, so to speak. And that is, that can lead to other problems as well. So what are some of the causes of chronic kidney disease? Well, high blood pressure. A lifetime of not having good control of blood pressure can cause kidney disease later in life. And, you can also, if you have any of these other vascular things like diabetes or these other high cholesterol, these other things that can affect the vasculature, all contribute to a diagnosis of chronic kidney disease later in life. And also something that I didn't add in earlier that I should have added earlier in all of these talks is that smoking. Nicotine damages the small vessels in your body. So if somebody is smoking, has high blood pressure, has diabetes, you can see all of these things are a recipe for disaster. They're all damaging the vessels in your body because nicotine constricts the vessels and damages them. And actually it even makes your blood pressure higher. Smoking does it. So it damages things in two ways. So smoking is very, very closely linked to high blood pressure, and it's very closely linked to chronic kidney disease as well. So now to talk about like the visits with doctors and how often you want to be seen for chronic kidney disease. And typically the answer is the same as it has been for the other things. If something's well controlled, all you're doing is kind of just watching it. An annual visit to the doctor is good enough. Sometimes if a doctor is, if a primary care doctor doesn't feel that they're controlling somebody's chronic kidney disease in a way that they're watching this creatinine number, GFR, these other blood tests, and if they don't feel like they're controlling it well enough, then they'll refer that person to a nephrologist or a kidney specialist. But one way that you manage kidney disease is to manage the damage of those vessels. So it's up to the doctors, or providers, primary care doctors, whoever it is, to keep people's blood pressures low, to keep people's hemoglobin A1C or the diabetes number controlled. So for example, back to one of Catlin's points about, the number being different based on the population. For example, older people, maybe you don't need to keep their blood pressure as low. This is a really important part of controlling chronic kidney disease and reducing the risk of damage, worsening damage long-term, is actually keeping blood pressure as controlled as possible. So even if you're older and you have chronic kidney disease and you have high blood pressure, your doctor is going to do their very best to keep your blood pressure 120 or less. And that is a standard. The goal should always be, because if it's higher, then you're continuing the damage, and we already know that person might already have damage. And then the goal for like somebody older for a hemoglobin A1C, the number is 6.5, like a 65-year-old with diabetes with no other issues. The goal might be 60 or 6.5 for a doctor. But if somebody has chronic kidney disease and they're being watched for their chronic kidney disease, that number then goes to 5.5. So you can see there's a lot more of like an urgency to reduce the worsening of this disease for those patients. So, and then to then go to like what the treatment is, really the treatment is reducing the damage, watching it, and then like as things progress, it becomes a lot more complicated. But I'm just talking about like early chronic kidney disease right now. And I have a picture of somebody on hemodialysis, and just to clarify, the photo that is somebody with like end stage kidney disease. That if somebody's needing dialysis, then that's end stage kidney disease, and that's not exactly what I'm talking about right now. But that's a visual for chronic kidney disease, I guess. So when it becomes an emergency is if somebody, typically this chronic condition is not an emergency unless somebody is on diabetes or on hemodialysis, and then that's like more of the end stage chronic kidney disease. And if they miss a dialysis session or they miss 2, and then they have this like, you know, change in cognition, if they're nauseous, throwing up, weakness, all of these things shows that there's like a buildup of toxins in the body. So that would be like a reason that it's an emergency. But otherwise, like an annual visit to the doctor is for early chronic kidney disease is typically what you need. And then it increases from there based on the needs and if things aren't well controlled. And those are all through blood draws and labs. Okay, now I'm going to talk about cancer for a second. And cancer, okay, I'll make this one kind of quick because this is another one where it's like, how does this really relate to cardiovascular disease? Because the fact is that they're not directly related, and but they are very closely linked, believe it or not. So cancer is when your body is growing cells in an uncontrolled rate. It is caused by all kinds of different things. It can be caused by a genetic mutation that you're born with. It can be caused by a genetic mutation that is caused by something like an outside source, like smoking or like damage to the skin with like sun. That can actually do damage to the DNA, cause your genome to change, and like then it starts replicating cells at like a different rate that's not controlled or checked. And that's essentially what cancer is. So, and then ultimately, if you know that progression and like the cell growth goes unchecked for a long time, then it can inhibit normal cells from growing. So then I want to just talk about like cancer screening guidelines, because cancer screening guidelines are going to be like the most important thing that you can do as like a patient, as an advocate for a patient, case manager, making sure that a client is going to the doctor to get their cancer screening. That's like one of the biggest things that primary care doctors do in terms of screening is for a cancer. So it is very, very different for the different types of cancer that exist. I have this is, I think, from the CDC's website about what screening guidelines exist for which types of cancer. And they have all of the most common cancers that exist. And for men, the most common cancers are prostate cancer, lung cancer, and colorectal cancers. And and a lot of people know these things, but like colonoscopies every 10 years, starting at the age of 50. But you know, that's not the rule for everybody. So you should always talk to your doctor, or like have your clients talk to their doctor about these things, because you know, it depends on your family history. If there's a family history of colorectal cancer or something like that, especially at an early age, your doctor typically will say like 10 years earlier than the youngest person in your family when they got it. That's when we want to start screening, stuff like that. So again, it's very nuanced. And this is just meant to like get a big picture of like what this screening looks like. And I think a lot of people know about testing for cervical cancer for women begins, this says at age 21. I think like several years ago, it used to be 16, but again, it's different for everybody. Ask your doctor what's best. But it's usually like a pap smear every 3 years. But then again, if you have a personal history of like HPV or something, then it goes to every year, and it's very nuanced, very different. So risk factors, like I just mentioned, like family history. I just mentioned HPV, family history, HPV, obesity, history of smoking, alcohol intake, high blood pressure even, can be reasons that somebody might say like, let's do your cancer screening a little bit differently. So it's different for everybody, but there is like a gold standard that most physicians will go by. And then one thing that's recent in the last like 7 years, 6 years maybe, is like prostate cancer. They don't check prostate specific antigen through the blood anymore. That used to be the gold standard. So you can see these things are like always changing. But checking like men getting their prostates checked every year by like their doctor is like pretty normal though still, and just not getting the blood draw anymore. So there is a link. I think the thing I wanted to focus on here is like the screening is complicated. There's a link between cardiovascular disease and cancer. So there is not, nobody, I don't think that like there's data out there that says one type of like high blood pressure leads to one type of cancer necessarily, but there is a relationship that exists. That's what the science says. So, and then in terms of when it becomes an emergency, this is a really long little thing that I'm not going to read, listed here on the slide. Bottom line is cancer emergencies are very complicated. And if somebody has a known history of cancer, the emergencies and what can happen as a result, kind of, it runs the gamut and it's very complicated, and I honestly won't get into it. I think I was going to earlier, but I don't think I have time for that, and I don't think it's going to benefit us for this talk anyway, so I'll go on.
Is there anything about, never mind, go. Finish this and then we'll be at the break. Okay. So the next thing that this is also going to be kind of quick, which is that there is also a link for dementia and cardiovascular disease. There's also like a vascular dementia that exists, and that's like a specific diagnosis that needs to come from a doctor, but there is a very close link to dementia and even Alzheimer's, and a lifetime of like cardiovascular diseases that like are unchecked. So this is something that I just kind of wanted to talk a little bit about, like what the primary care doctor's role is in dementia and Alzheimer's. And that is like an annual visit and making sure that somebody's blood pressure and cardiovascular disease is controlled. And usually a doctor will want to see somebody the same answer that I give every single time, which is every year if things are controlled. But then if somebody's cognition is, worse and worse, getting worse and worse, and nobody can give a specific reason for why when they have a known like dementia diagnosis, then that prompts a reason for going back to the doctor. That's different from somebody's cognition getting worse related to a specific event. Say an older person was removed, or somebody with dementia was removed from their home, put in the hospital. Those are exacerbating events that can be explained. Or if they're very constipated, again, an exacerbating event that can be explained. People have these exacerbating dementia or like cognitive impairment events that can be explained by other things. But if it's not explained by other things and it continues to get worse over a course of like many weeks, then somebody needs to be seen by a doctor. And when it becomes an emergency is when there is like aggressive, unsafe behavior, if somebody's wandering into unsafe situations. And then, like I said, persistent exacerbation with an unknown cause. That's also a reason. That's maybe not like go to the emergency room emergency, but that's like get seen by a doctor in a quick fashion for sure. And then, there's a point where especially if there's like a diagnosis of like a vascular dementia, Lewy body dementia, these things that are specific to vascular disease, then oftentimes, the primary care doctors are not going to be responsible for managing this as well. Like neurologists are often very involved in helping control these things and putting people on medications, and can be very helpfor because dementia and cognitive impairment is a beast of a thing to talk about, for family members to
go through, for the patient to go through. And that's why there's so many like community services and specialists and things that are related or that are available for these folks, because it's very complicated and it's really hard to treat and hard to control. And that's why I wanted to add it to this talk, is because it's one of those where you have a chronic uncontrolled vascular problem your entire life, how it can lead to things later on. So that was the reason for adding the dementia talk into this slide. And then the last thing I want to add in this talk is racism and cardiovascular disease, because this is very well researched at this, well, not well researched enough, I should say, but it's becoming more talked about, more researched in the last several years. And that is that cardiovascular disease specifically affects Black people and Hispanic people, but specifically in the United States, Black people, more than any other group of folks in the entire United States. And the fact is that medicine has been very behind in treating cardiovascular disease for Black people in the United States. And the reason has been talked about a lot for why this has been happening. And historically, like if you read in some medical textbooks, it will say that there are certain medications that don't work as well for Black people that have high blood pressure. And that is true, that has been researched, but the fact is that there are medications that do work as well and that work just as well. So why is it that actually there's a huge disparity? And there's a statistic that I wrote down that I want to just read, which is that Black people in the United States, 2-fold higher mortality rate related to hypertension. And this is from a study that's compared to white people. That's from a study in 2018. So per 100,000 people, Black men, 206 of them would die from their cardiovascular disease or high blood pressure. Sorry, this is specifically high blood pressure related to 117 white men. So that is double. And I think that the thing I wanted to really focus on here is that there is not enough research into and not enough conversations going into why access to care is an issue, why there has not been more focus on making sure that blood pressure, specifically cardiovascular disease, is not better treated in our Black communities. And this is just a quote from a book about racism in medicine. Our analysis underscores how little progress has been made over the last 18 years in reducing hypertensive-related mortality among Black Americans.
And the San Francisco Community Health Plan that I started this talk out with says the exact same thing. And that like this specific issue in San Francisco happens just like it does in the majority of the country. But yeah, us, I guess I will say us, but yeah, like the Black community in San Francisco carries more of the load for cardiovascular conditions and hypertensive conditions. Yeah, that's all consistent with what the specific San Francisco statistics bear out, especially with exposure to trauma and violence. Yeah.
Thanks, Ashley.
All right. Well, that's a lot covered. And so the questions in the chat and also in the Q&A, we'll start to address. Yeah. Thanks so much, Becca. That was really
thank you.
Very informative and thorough.
So there are, let's see, let me look up and see. The most relevant question we have for smoking is someone saying I have a client who uses cannabis to treat glaucoma, and does that have any impact or risk for kidney disease?
No, but also I do want to say one thing about cannabis use, which is that it's been illegal for so long, like federally, that there's not a lot of research out there about it. But but cannabis use for glaucoma, I think there is some data to support this. And then also, it's best to not just smoke cannabis. Like if you are going to use medical marijuana, that actually smoking it is probably not the best thing because you're still putting smoke into your lungs. But just remember that, yeah, like cannabis and nicotine are not the same thing, and there is not the same association with like cardiovascular problems related to the use of cannabis and like nicotine and tobacco.
Okay, awesome. So then Q&A, there's two questions, and none of them specifically relate to the 4 conditions that you just covered. They're mostly about HIV. So I guess we can cover those, and then we got 10 minutes. I know that you were wanting to take a break, but seems maybe 5-minute break in 10-minute time doesn't make a lot of sense. So I guess we got a couple options. So I'll pose the HIV questions, and then you can decide to either answer them or we can finish the conversation on medical system of care. So the questions are, how do you identify the difference between weight gain and inflammation in HIV? And then another question is, this one's a little hard to parse exactly. Well, okay, let's just do weight gain, inflammation, and HIV.
I'm really sorry that I don't have a lot of experience and expertise in this. And if I could just say that I appreciate the question, and I'll better educate myself on some of the problems that this community has to deal with, and like maybe if I better educate myself, then I'll better be able to answer that question. But if I say something now, I just don't know if I'm going to be answering it the best way possible.
I think that is role modeling how to stay within our scope.
and it indicates the future need, and thank you so much for sharing that. Because definitely, I think you're representing an area or a group of people that we definitely need to address some health issues too. I think there's thank you, keep the questions coming, because it does definitely keep us on our toes and point us in the direction of our own personal research as a team. The other question it's more of a comment from Heidi with regard to ovarian cancer. It says that there isn't a standardized screening, and yet it's a horrible cancer. So to be aware of, not ignore symptoms. So maybe you can speak a little bit to that. Like, are there things that people can watch with regard to ovarian cancer?
Yeah, unfortunately, ovarian cancer is kind of one of those cancers that there is not a good screening for. It's like, it's a very terrible cancer. And part of the reason is because most of the time when people get diagnosed with ovarian cancer, it's too late to do any sort of curative treatment. And that goes for a lot of cancers, actually. And it's the scariest thing about cancer, is they have all these screening guidelines that exist for the ones that they can screen for. But the only way to find like an ovarian cancer early on is like to do a CT scan of somebody, and not everyone's going to go in and get a CT scan every year, and nor should they, because CT scanners actually have like a lot of radiation in them and stuff, so there's not like a great benefit of that anyway. It's scary. I mean, I don't know what to say other than like that's not the only cancer that's terrible and only found later in life or later on in like the progression of the disease. Pancreatic cancer is another one that I'm thinking of. Yeah.
There are other things. Ashley, let's see.
Yeah, I think with the next two are just talking about the medical kind of system of care. We're done with questions, Becca. I don't think there's
Oh, great. Sorry, I didn't realize that. Okay. My bad.
No, you're good. Okay, so this one is just a broad overview of the San Francisco ecosystem of care, and this kind of harkens back to the reason we made this a module training in a series, because we've covered mental health, substance use, and housing in the previous trainings, and this is the medical one. So the far left is going to be your urgent and emergent care. And then the middle is transition and stabilization. So this talks about all the ways in San Francisco, if you are in the emergency room or at the hospital, what you do after, and then recovery and wellness are the many options you have in San Francisco after you have stabilized. That's not really as important as the slide after, where Becca will tell us a little bit about each of the levels of care. The pictures on the right side you'll see are the two main urgent care options in San Francisco. One is 50 Ivy Street. It's right down in Civic Center. It's the old Tom Waddell Clinic for people who were San Francisco providers before Tom Waddell moved up to Golden Gate. And then the other is at General Hospital. So yeah, in our last 5 minutes.
Yeah.
Let's walk through what these levels of care mean, what people can expect.
Yeah, let's do it.
Sign up for Medical Harm Reduction Part 2, where we'll talk about how to talk to your clients about these conditions and supporting them on what they want and feel ready to tackle. All right.
Before you do that, 30 seconds just to mention that in the chat, people have recommended books to read with regard to deep medicine and the anatomy of injustice. So take a look at that if you can copy and paste so that you have an opportunity to look into it a little deeper. And also some suggestions for more information related to diabetes information. So just if you guys can, for the next 30 seconds, just take a quick look at the chat and see that there are actually resources that the rest of your colleagues have also added.
I'll also be putting the link to our training evaluation, which is separate from Catlin's evaluation. Our SurveyMonkey evaluation will be a way that we can get your perspective on what you thought about the training and further training ideas that you would like. And Catlin has a separate training that she'll send out, which will be for IOA and for CEUs. All right. So keep an eye on the chat for that link.
Thanks, everybody.
Okay. I'm just going to kind of power through the different places in the hospital, what happens in each one of them, and then I'll let you guys all take the rest of the time to focus on the stuff that's in the chat that my colleagues just mentioned. So thank you, Ashley and Ann. I'm going to start with the emergency room. Emergency room is where clients, patients, people going into the emergency room can be expected to be triaged. And like typically what happens is you go in and you'll have the first thing is like somebody checking you in, asking you like the ABCs, airway, breathing, circulation, like making sure the most basic functions of life are working and you're going to be kept alive basically. And once you check off that mark, then you're going to be moved on to like a triage nurse. And then the triage nurse will kind of get into like a little bit more about what exactly is going on, where they'll determine what type of emergency this is. And then that triage nurse is then going around collecting that information to everybody in the emergency room coming in. And then there's a whole algorithm and process that puts one person in front of another and bumps maybe somebody with a not so emergent condition down a little bit lower. So that's why people end up waiting in emergency room for hours. It's because more urgent situations come in, you know, even after you. But so one thing that Ashley and I talked about when we were putting the slide together is that one way that people can often defer the whole triage situation is like going in through an ambulance. And so if somebody needs emergent help, typically like it's reserved or coming in through an ambulance, all the triaging happens like in the ambulance, and that they don't really have to wait. They get like roomed into an emergency room like right away, where they're not waiting in the waiting room for a super long time. Okay, next there is an observation unit. So if somebody comes into the emergency room and, you know, there's labs collected and they want to see that something gets a little bit better in a course of like 24 hours, they might put you on an observation unit. This is where you see like patients sharing rooms because you're just there for like, you know, 12 to 24 hours, not a long time. Then, you know, you're there for like a very short amount of time, and kind of like you're in and you're out in the observation unit. And then if you stay longer than that, you go to the inpatient setting and the inpatient unit, which is where you're there for like greater than 24 hours. And those patients, I mean, typically like you have an entire team of doctors that comes and sees you every single day. And you have, you know, your nurse that changes every day, but you're always like on the same floor in the same unit with the same doctors coming to visit you every day, coming up with a plan for you and like determining when you might get discharged from the hospital, and like what your overall plan is every day. And that can be from greater than 24 hours to for however long you need to be there. And then the last thing is the ICU. And the ICU, something that is like something I want to mention is each one of these places, insurances charge a different amount of money. So if you are in the emergency room, you go to the observation unit, you might get charged a certain amount. If you go to the emergency room and then go straight to the ICU because things are so terrible for you, then you're going to get charged even more, or your insurance will. But the point is that there's a reason for these different admitting sort of like spaces in the hospital, and that's the reason, one of the reasons we're talking about it, because it is like it affects people, what people kind of like go home with, what kind of insurance issues they deal with. And the intensive care unit is, you know, where people are on breathing machines and need a much higher level of care, where they're being watched very closely and someone's in their room every single hour. So that's kind of the big difference between each of those places in the hospital.
All right, beautiful. Right at the line.
Ooh, wow.
All right, guys. So there's a link in the chat. If you want to copy and paste it from this slide, you can also do that. And that's our evaluation for the clinical collaborative, which is separate from Catlin's evaluation that you'll need to do for CEUs. Final question, Becca. Does the patient need to be in observation 3 nights before being admitted to inpatient as per Medicare's rule?
That is different for all different types of insurance. I'm pretty sure for Medicare's rule, to be honest with you, I always thought it was 24 hours. And then anything greater than 24 hours is an or no, maybe it's 48. I think it depends on each person's specific problem, but I don't know. Sorry.
It depends on the presenting problems for sure. I think it would be great to think that your insurance ought not decide how long you need to be observed.
Yeah.
But the reality is that it does. But if there's blood and gore, then obviously it's a quicker assessment, and they'll most likely determine whether you need inpatient admission or an ICU. So some of it is determined by what is presented in terms of your clients going to the emergency room, and also how thorough the particular hospital is in terms of doing all the lab works, the MRIs, the CAT, all of the diagnostics. But there's no such rule of thumb for insurance. But again, this is the best of situations. Not knowing all of the hospitals and what their general practices are. Yeah, but no, it really depends on the presenting symptoms and how thorough the emergency room is in terms of determining what labs and assessment tills to use. Yeah. Mustn't be determined insurance and money. Yeah, okay, great question though. You know,
I wish I knew more about it, honestly.
Everyone, it looks like we're at the end of our time. If there are any lingering questions, we can pull those and answer them in the email that I'll be sending out to everybody. Thank you, Collaborative, for doing such great work again today. And anytime you'd like to stop the recording, Becca, you may.
Thanks.
great. Thanks for coming, everyone. And yeah, your questions really make our work exciting, because the whole idea of it is to address community needs, and you make it all alive for us. Yeah, thank you.